Welcome to Praxis. I'm Olivia Rousset. I'd like to welcome our audience here in Sydney, as well as those watching on APAC, online, or listening on radio across the Asia Pacific. Today our panel will be discussing maternal and child health in the developing world. On our panel we have Dr. Nesrin Varol from the University of Sydney Medical School, Mahboba Rawi, the founder of Mahboba's Promise, a charity dedicated to the women and children of Afghanistan, and Dr. Nicole Wong, a haematology registrar from the Royal Prince Alfred Hospital, who spent a year working as a volunteer on the Thai-Burma border. This month, the not-for-profit group Save the Children released a report which found that Australia is the second best place to be a mother after Norway, and that Afghanistan is the worst, having the highest lifetime risk of maternal mortality and the lowest female life expectancy in the world. Today, 1,000 women will die from preventable causes related to pregnancy and childbirth. 99% of these deaths occur in developing countries. The orphan children of these women are much more likely to die before the age of 5. Nearly half the deaths of children under 5 occur in the first month of life. Most of these children could be saved by known, affordable and effective interventions. The Millennium Development Goals 4 and 5 commit to significantly reducing maternal and child deaths by 2015. But to date, this goal has made the least progress of all the goals in developing countries. Research tells us that 80% of maternal deaths in developing countries are easily preventable. Nesrin, I'd like to ask you first, what's the most important step in beginning to improve women and children's health in developing countries?
Well, I'm very happy to know that recently the international community has come to realise the importance of funding to maternal and child health. I believe that the number of women that die from pregnancy-related complications and from childbirth is a barometer of how effective a country is being governed. So providing women and children with their essential health care and education is probably the most important thing.
And Mahboba, what do you think is the most important first step in improving women and children's health?
I believe the first thing for a woman in my country is for the world women to care and for the world people to care for them, because these poor women have no life. As you said, they're the highest death rate of maternities when they're having birth is the highest level in Afghanistan. So we want people to care and give them facilities to live. Yeah.
And Nicole, for you, what's the most important step?
Well, the way I've come to view it is that if we start off with poor maternal health, it then tends to feed into poor child health, which tends to lead to diseases of adulthood, which are ultimately preventable. And this cycle, I guess, of disease and is one that I think has multiple steps of intervention, but one of the most important steps is probably in focusing on good maternal health so that we can see the rest of the cycle improve.
And what do you, in your work you did on the Thai-Burmese border, what were the main issues that you dealt with in the clinic?
Well, in our particular location, we were faced with giving healthcare to Burmese refugees who are living in largely in Burma, but also illegally in Thailand, in a clinic that's based in Thailand itself. And so there were issues of geographical access to the clinic, and people generally had to travel between 1 to 2 days to reach the clinic, but also issues of travelling cross-border as illegal migrants and the risks of being stopped by Burmese checkpoints and Thai checkpoints, having to pay off bribes and only then arrive safely at the clinic, which led to huge access problems. And those kinds of access problems meant that while it may be possible to treat people who arrive with diseases, it was often, and it is often, difficult to access those communities and provide health prevention. So that geographical and political instances, it was a major challenge.
So you had to wait for them to come to you. And what would they often come for, women and children particularly?
Well, women generally would access the clinic to safely deliver, and oftentimes were not able to come for antenatal care, and so their first presentation would be in labour, which is not an ideal situation, and potentially having travel days to arrive. They'd often have left situations where they may be the main caregiver for children back inside Burma. So there are issues with leaving families back inside Burma, and also they may still have been a major breadwinner, and so there's economic loss as well when they're away from home and jobs for that period of time. We did try as a clinic to feed local people back across the border, which is dangerous to the healthcare workers themselves, who can be targeted by Burmese military for that kind of activity.
Sending medical staff.
That's right.
Yeah.
Not foreign staff, but local staff back cross border into the villages. But that's at quite significant personal risk to them.
And you were talking before about the sort of holistic thing. A woman comes across in labour and she may bring other children. What do you do? I suppose you're taking every opportunity you've got in that kind of situation.
Yeah, no, that's right. I mean, a woman arriving at the clinic to give birth is a great opportunity to educate her about the nutrition and care of her child, to educate her about appropriate weaning foods to prevent malnutrition in the kind of 12 month to 18 month risk period for a child, and then also to take a look at the children that she's bringing with her and see if they're well nourished or if they have any signs of early disease, to ask them how many times they've had malaria, and to try and figure out what other preventative strategies you can put in for that family. Hopefully some of that knowledge and education they can take back to their village itself.
Can you outline the common health problems that the women who come across most often face, and for children as well?
For the women as well as children, nutrition is a major issue. I was working in Southeast Asia, where generally food is abundant, but because of the kind of political pressures of military regimes moving through villages and pushing people out of arable land, there is actually a real shortage of food. But there's also, for children whose mothers are working in fields, there's lack of access to appropriate foods for young children. They may be just eating inappropriate weanable foods. So malnutrition is a huge issue, and then that leads to susceptibility to communicable diseases like malaria and also tuberculosis, which is still major problems along the border. And certainly through better nutrition and addressing poverty, I think those diseases are certainly reducible.
Can you talk a bit more about the frustrations working with sort of inaccessible government? Like Nesrin said earlier, that the barometer of a healthy government is the situation of the women and children there. What have you noticed generally, or what have been the challenges? So on the Thai-Burma border, we're in a situation which is common to other areas, where you've had NGOs providing healthcare to a population over 20 years who are unable to engage the Burmese government to provide systematic healthcare. So instead, there's a pseudo health structure that's set up on the border. But unfortunately, like any situation where multiple NGOs need to cooperate with each other, there's varying levels of cooperation and different programs that are running at different times. Some successes have been that some of the programs like ours have engaged the Thai Ministry of Public Health, and we had quite a good relationship with them, and they would help us to address issues like disease outbreak, in terms of cholera and measles, and we appealed to their sense of wanting to protect kind of public health in Thailand as a way of engaging them to provide some support for Burmese refugees' health as well. So there's been some success in that. And what about stories of the other challenges faced? Because crossing a border in labour or pregnant is not, by no means a comfortable exercise. What are some of the other risks that women face there?
Look, while not in the majority, there are risks to women in terms of just basic security. So women who cross the border from Burma to Thailand illegally generally have to pay bribes as they come, and then once in Thailand they pass through several checkpoints, and if they're unable to pay the bribes they are put into detention and then sent back across the border to Burma. Unfortunately, on the Burmese side, local militia hold control of that particular area, and the women are again detained by the local militia and held basically for ransom. So I did receive a phone call one evening saying that there was a 36-week-old pregnant woman who was sitting on a concrete floor in a house in Burma and wouldn't be released until a bribe was paid. And we know that intellectually you don't want to participate in that that kind of operation, and it perpetuates a problem. But there's significant risk with a woman in that stressful situation, sitting in a place where if she did go into labour and there was a problem, she and the baby may be at risk. And so unfortunately I was pushed into a position to decide whether or not I kind of did help in that situation. And I guess the mediators in that situation were locals who knew the implications of paying or not paying, and they just said to me, look, we just think in this situation that the outcome for her would be bad if we don't. And so we got her over and she delivered safely in Thailand. And I don't know that you can, I think you need to go many steps back to try and prevent that kind of problem. In terms of providing security to women who are coming across. So,
and just finally, do you have a sense of how many women come, or how many just give birth without seeking assistance? Like what kind of?
Yeah, that's a very good question. It's just.
Or why do they come? Is it women who are assuming there will be problems, or have had problematic births previously, mostly, or?
I think that the women come opportunistically. The clinic, there's a lot of word of mouth of knowledge of not only our clinic but other clinics on the border, and so if they can come, they will. So we know that in 2008 there were nearly 2,500 deliveries at the clinic, but the problem is that we actually we have no knowledge of real statistics of maternal mortality and early child mortality in Burma. And there are published figures, but they're very difficult to trust because the information gathering is so limited.
Thank you. Mahboba, you set up your organisation to provide food, shelter, education and medical attention for women and children in Afghanistan, and you're now caring for 500 widows and several thousand children, I believe. What are your main concerns for the health of these people?
There is a lot to be concerned for Afghanistan women and children, because they suffer over 40 years of war, and as a consequence of that and high level of poverty, people suffer because there is not much hospital available there. So many people have diseases. They have to cross to the next border of Pakistan or Iran or India to go and treat there, because there is not much resources available for them in Afghanistan, as you know. So there is a lot to be concerned, and especially when they come to the women health and preventable diseases, like simple things like hygiene is killing people. So there's so much to worry and concern about these people.
What is the standard of childbirth in Afghanistan? How generally is it done? Are there facilities, are there hospitals that provide for the women?
There is not much family planning. Before war, we used to have family planning center, resources available for women. After the war, everything of course demolished, and there is not much available except a few German people built some hospital, French hospital, and there's a few hospital, but 30 million people living in health circumstances, like, many people grow up in war situation. Their health is of course jeopardized by that, and so there is not much resources available for them to use. and that's why they're suffering.
And Afghanistan has the highest birth rate in the world.
They do that in. I mean, I saw there's some only as far as I remember, there's one maternity hospital, and the woman should have to go and give a birth on the floor, and they have to get up quickly and take the child home, and usually they will get infection after that because they have to go quickly off from the hospital. Yeah, I mean, many women dying from birth diseases, and I have some good some example which is very, very sad, and I just thought I just share it with the audience. That 2 years ago I was in Afghanistan, and one of my cousins gave a birth to a twin child, and she just died because of infection, and her 8 years old daughter, she became mother of these twins. So not only her life destroyed, the little girl life is destroyed. So there is many stories like that in Afghanistan in every corner, and I think women lose their life as a result of birth. And there's these people are so poor they can't even buy medication to prevent having more children. I mean, they live in a society they can't afford to buy food. Forget about medication. So.
Can you talk a little bit about, Nicole referred to the sort of the cycle, once the mother's affected or the mother dies, then the children, their life is compromised. What kind of issues and health issues do you think come up for children?
Yeah,
orphans?
I mean, that's a big part of my job, over the 12 years that I dedicate myself to look after the children who lost their mother and father, and I've seen them, and the majority of these children ended up going on the street and begging in order to survive. So that's why I built the Hope House, and I go to the street of Afghanistan and take them and put them in Hope House to give them education and a bit of
Hope House is the orphanage?
It's a orphanage, and I built Peace House next door to Hope House so they can learn something and give them some training. The health of these children is pretty bad, not only emotionally, physically. I mean, kids grow up in the war zone country. The first biggest things for them is mental diseases. Sometimes as a joke, I say in my office in Kabul, I said I couldn't find one healthy person to employ to run some of my orphanage, because every one of them suffer from some sort of mental health diseases, and women suffer from losses. I mean, women consider themselves lucky if they lost 1 or 2, 3 members of their family. And I lost one of my son a couple of years ago, and when I went to Afghanistan and I saw women consider themselves lucky if they lost 2, 3, and then it helped me to grieve better. So that showed the level of poverty, nutrition, lack of resources these people go through.
So beyond getting the world's attention and obviously resources, what do you want to see put in place in Afghanistan for women and children like those under your care?
Well, I want them to be a good leaders for the future of Afghanistan, and give them education. I believe education is a key for successful for Afghanistan. If we give them education and give them basic necessity of life and make them understand the world, they will stand on their feet, and they become better citizens rather than I believe this kind of help will help Afghanistan become better for the future of Afghanistan.
And as far as the health system goes, you started up a hospital or a couple of hospitals?
In 2003, I built one tiny, small medical center in a remote area in Afghanistan, which people walk hours and hours to go to Kabul. And when I built this medical center, at the first week, people start praying in the morning, 5 o'clock, and there is a queue of women and children, and the doctor was really can't cope with the level of demand. And I opened a pharmacy full of medication, and I was so happy, pleased with myself that the pharmacy is full of medication. Within 1 week, everything is gone. And And I know the demand is so huge. Like, it's quite obvious in Afghanistan. If you go and look at the children, you can see skin diseases. You can see they're suffering from all these bombing and fighting. The consequences of war have huge impact on poor people, and mentally, physically, emotionally, and they need so much attention. So within 1 month, the doctors see thousands of patients. Within 1 year, he resigned. He said, "I can't work with you, Mahboba. There's so much demand." And we got a tiny room for women to come and give a birth. And so people walking from different villages to come to our clinic, and we have very tiny basic facility there. And it was very difficult for us also to keep it up. And Variety Club in Australia helped me build another medical center in Kabul, and that's close to my orphanage. And to give an example of how the people not even think about health issues, like dentists. The dentist working for the orphanage, and we have 120 in Hope House. Almost every child have to take off 1 or 2, 3 of their teeth. And the health for the woman coming, 500 widows under my care. Soon we run out of medication, and if you give them prescription, they don't have money to buy. And if you want the woman to prevent having more children, because the families is big families there, like every woman have at least about 10 children, and they said they can't afford to buy any
contraceptives.
Yeah.
Nesrin, I'd like to come to you. Thanks, Mahboba. You've done some work with governments with the government in Ethiopia. What do you see as the role of the government in improving maternal and child health?
Well, I've just come back working in a remote part of Ethiopia in a small village as an obstetrician and a gynecologist. It was one of those places where I sort of went there thinking, I'm an Australian doctor, and I'm going to help them and I'm going to teach them, and you come back having learned about 1 million things more than what you taught them. And you learn so many things about life and even about medicine from the poorest people on earth. So the Ethiopian government is implementing a program called the Health Extension Program in response to the failure of essential health services reaching communities in remote parts of Ethiopia. And they have trained more than 300,000 health extension workers who go out to the communities, knock on the doors, go from household to household, and work with the community at the grassroots level to educate them, to empower them, to help them, to basically listen to them what they need, to improve the gender equality and the equity access to the healthcare system. So having had the first-hand experience in the hospitals, I found that the most pressing things were that, first of all, women may not even be able to get to even the little hospital where I was because of the distance. They often live in quite mountainous areas there, and they can't have transport to get to the hospital. And even if they get to the hospital, they might not have the money to even pay the little bit of fees that they are asked to give. And even if they can do that, there may not be any medication, or there's no doctor, or there's no surgeon. So when you look at it, it's actually easy to solve. And you need just a few passionate people who are quite dedicated on the ground, and with obviously the support of governments and support of developed countries like Australia and NGOs and and the private sector as well, where you can make a significant change. The time that I was there, for example, women who had obstructed labour, who normally probably would have died because of hemorrhage, or the baby would have died because the next town was 3 hours by car on a very mountainous and uncomfortable road. So, I could provide their cesarean section or their delivery there. And as an example, for example, there was a 12-year-old little boy who had pain for about a week at home. He was quite toxic by the time he came. He was writhing in pain. He had a ruptured appendix, and he probably would have died if there was no surgeon there. And we operated on him. And the parents, were so grateful.
And what kind of thing, you were talking about how you learnt so much from the people there. What kind of things?
From the doctors and the anaesthetists there, I learned maybe how to get by with things which we're not, we have the best here. If you don't like something, you just get another one. But there you make by with things, and it actually works.
And if you weren't there for that boy or some of these women, who would have been there?
No one.
No
one.
One.
There was nobody there. Yeah. So my work with the Ethiopian government is really to build capacity and to train them so that when we leave, that they can have, it's all working for them, and just basically helping them in their programs.
It's like Mahboba talked about, women in Afghanistan feel lucky if they've lost 2 or 3 members of their family and not more. I think something we talked about earlier, in the West there's this perception that suffering and death and loss of a mother or loss of a child is to be expected in some of these countries.
Yes.
So therefore it must not be quite as bad. What's your experience?
Yes, and I'm guilty of that as well, because with all the media that we see that there's so much famine and starvation and wars and conflict and diseases that people do get used to it, and that was my impression as well. But I was so wrong. A woman who loses a child in Africa feels the same grief and the loss just as much as a mother in Australia does. An example, there was another boy who was operated on, and as he was coming out of the operation theatre, he was still, anaesthetised and was lying still with his eyes closed because he hadn't quite gained consciousness yet. And his mother thought he had died. So she went into a coma for 3 days. We admitted her to the medical ward because of shock. And I've never seen that in Australia. So and then when she gained consciousness, she couldn't remember anything. I mean, she remembered she had a son, but she just couldn't. So that just showed me that it's the same. A life in Africa is just as precious as a life in the US, as a life in Australia, as a life in Europe.
And also every child deserves to live better life. Like if we want our children to have everything in the world, that we should think about children who live in poor country. They should at least have basic necessity of life. Is to care for them and to not to put blind eyes on people and say, look, they're suffering too much. There's so much suffering around the world. What can I do? We all getting overwhelmed because we put the TV on and we know all the world problem in 1 minute. And what can we do? We just ignore it. So many people ignore it. But to share what we have with the rest of the world will be a better place for everyone. And I believe that every child deserves to live okay, like our children.
And it's the thing of, if it's in front of you, if you see it, if you know it, if you've experienced it, you can't do anything but care. But when you're removed, it is easier just to look at home.
Yes.
And many children born in countries like all these chemical go for the war. They're born immature and disabled. In a country like Afghanistan, if you're born disabled, it's best for you to die. And what kind of life these children have? And sometimes we're so lucky in Australia to see some of these handicapped children is receiving so much attention and care, which is really good, and they deserve to receive that around the world as well.
There's just one thing I wanted to ask you, Nesrin, before moving on to questions, but your work has also focused a lot on female genital cutting. Can you talk about the impact of that on maternal health?
Yeah, sure, thank you. So female genital cutting is a procedure where it basically involves cutting partially or completely the external female genitalia in women and girls. It's done between the ages of birth to ages of 15, usually without any anesthetic. And then sometimes the vagina is sewn just to leave a little opening. It is performed in about 28 African countries and also in Asia and the Middle East, and in communities who have come from those countries, migrated to Australia, New Zealand, and to the US and Europe. It has lots of short and long-term complications. A landmark study by the World Health Organization has shown that in the more severe forms of FGC, female genital cutting, women have a 55% higher chance of having a dead baby, of having a 70% higher chance of a major hemorrhage at delivery, and a 30% chance of having obstructed labour and requiring a caesarean section.
Which wouldn't be available in most situations, the caesarean.
Exactly, and then that can also then lead to obstetric fistula, which means the baby then dies, and the pressure of the head then causes breakdown of the tissue from between the vagina and the bladder or the bowel, and those women then can leak through the vagina, and that's, you know, it's a very terrible thing to happen. So it's a practice that has multiple reasons for it. The main one being marriageability, and also the perception that it will that it is important for chastity and virginity and to uphold the honor of the family. It's also a rite of passage from childhood to adulthood in women. Whilst we see it as, you know, as a torture or whilst it is de facto violent, it is not like that from the women who then perform it on the daughters, because the benefits outweigh the disadvantages of having that procedure done. So if you're the only daughter who doesn't have it done, then you'll be ostracized and you don't get married, and being married is very important for the livelihood of women in those developing countries.
What can you do to try and stop or change it?
Yeah, so the most effective programs have been those that have been built around the principles of human rights and gender equality, that are non-judgmental and non-coercive, and where the changes come from within the community and been embraced by the community. So it's very important that the advocacy starts by really listening and hearing the woman and seeing what impact it has had on their lives and what they feel, what they think is important for them. Otherwise, we risk imposing our Western value and our notion of human rights and quality of care to those women, which then again leads to oppression of those women and invasion of their culture, invasion of their beliefs, and they have beautiful cultures. If you've never been to Ethiopia or to Kenya, it's fantastic. I've got the Africa bug, and I can't wait to go back.
Is the government supporting your initiatives to change it in Ethiopia?
Oh, absolutely, that's right. So the changes have to be at multiple levels. I find that the changes in the developing world work best if you have people at the ground level who really oversee it and work with the communities, but then also at multiple levels across the world, as well as institutions of law, justice, education, non-government organisation, and the private sector. So everybody has to be within it. And most countries in Africa have actually outlawed it. But again, you can outlaw it, but if there is a demand, it will still continue. So you have to work with the communities, and I find that when you work with them, you don't even talk about that. You talk about human rights, you talk about that you have the right to health, you have the right to be free of oppression, and you have the right to have a voice, and you have a right to make a decision about your lives and that of children, the right whether you want to be married and to whom you want to be married.
We should actually open up for questions now. Would anyone from the audience like to pose a question? Just over here, just wait for the microphone.
Good afternoon. My name is Michelle Rumsey. I'm from the WHO Collaborating Centre at University of Technology, Sydney. I think we're all incredibly relieved that the world's woken up to MDG 4 and 5, because it's taken a long time. We're 10 years into the Millennium Development Goals now. My question's twofold. One is, why do you think it's taken us so long to wake up to MDG 4 and 5 when many of the other Millennium Development Goals have been worked on during this last 10 years? And WHO quite clearly shows that an increase in midwives can significantly reduce maternal health and child health. And again, I'm just wondering what your opinions are about that debate, because we really haven't seen the midwives involved in the MDG debate, and really just asking you a question. Thank you.
Just before you do, MDGs 4 and 5, as most of you may know, is basically aiming to significantly reduce maternal and child deaths by 2015. Who would like to? Nesrin, would you like to start with it?
Sure. Yes, thank you for the question. That's very good. I've always found that as a gynecologist, women's health and children's health often has taken low priority. It's because when you look at the world, that the poorest of the poor are usually the women in the world, and they often have less power and less ability maybe to speak up for themselves, and they're often dependent on other people. And so there is no impetus from them to lobby, maybe. That might be probably the main reason. But it looks like it is changing, because maternal health, once you educate and give health to women, and as Nicole explained with the cycle, then they can educate their children, they'll be healthier, they can choose how many children they have. And it's actually the key to poverty. Everything stems from that, and they have now realized that. And the second part of your question
was about training midwives.
Yeah.
Nicole, would you like to?
Yeah, no, absolutely. I think that in the area where I've worked in, I've seen some amazingly successful programs in midwife training, where you take a program that's internationally recognised, when there are several that are applicable to developing countries. There's an advanced life support of obstetrics that's quite trainable to people with very minimal health skills. In our clinic, we would train people who had a Year 10 level of education and did some basic healthcare worker training locally inside the clinic, and then went on to this midwifery training. And the advantage of training centred locally is that of course then you want to train trainers and have that program be self-sustaining. In our experience, we had that kind of long-term support of some funding through Columbia University, which kind of has promised 5 years of funding, not just to solely training midwives or personnel, but also to bricks and mortar training. And I see so often that sometimes those two funding streams are split, and people either want to sponsor a building where they can perhaps put their name or their organisation's name on it, or they only want to sponsor medicines. And so this kind of holistic idea that you need a location, a clean building, plus trained staff, and then you need to train the trainers is really important. And it needs to be to a program that has a standard that people are happy with, not just a standard that's okay for a developing country, but actually a standard that's an international standard, because we shouldn't have different standards for childbirth in developing country. So yeah, no, it's a very good
Mahboba,
question.
is there sort of midwife level support in Afghanistan generally, or?
We used to have these elderly people with experience, with not educated, but they have experience. So usually they're very, very old. Somebody have to go hold their hand and come and bring them to give a birth to to the baby. We used to have this before war, but after war even they die. So there is a quite good things to just train some people to become midwife. And of course in Afghanistan, because women is not educated, so probably practical how to do it would be more appropriate for that society.
Any more questions?
Thank you so much. My name is Thelma. I'm a student at the University of New South Wales, and I'm doing public health. Just want to ask a question for three speakers. We all knew that one of the key indicators that also is recommended by WHO is to actually promote any delivery attended by skilled birth attendant. However, this been promoted in early 1970s, but then the evidence show that some of the traditional birth attendants that promoted by WHO in 1970s did not show any evidence. And we see that many less developed countries has issue with lack of trained midwife in those countries. So I just want to ask about this opinion from these three speakers who are, based on your experience, what do you think about promote these traditional birth attendants as mentioned by the one of the speakers from Afghanistan about train those community elderly women that trust by the community to deliver this help the mothers during the delivery and pregnancy and postpartum care. What do you think about this promote of traditional birth attendant? Thank you.
Nesrin, I imagine in all countries where there aren't established strong medical systems, there are women, I assume generally women in communities who act as midwives. What have you seen in Ethiopia or other places?
Yeah, I mean, obviously midwives and trained birth attendants, are essential for the delivery for a safe delivery where there is no doctor. And in the villages where I've been working, the midwives do pretty much what a doctor would do here. They are amazing. For example, we didn't get called for a twin delivery or for a normal vacuum delivery. They do it all. So, and we could teach them how to do cesarean section as well, for example. And I think it is very, very important. And my work certainly is going to focus on, doing the work with our nursing college here and the midwives, and the governments in Ethiopia also do the same.
You think that the medically trained midwife attendant is obviously a much better option than a traditional untrained midwife? Are they recognised, the untrained birth attendants?
They are recognised, and I think what the government is doing is teaching them and maybe upgrading their skills, so they are more trained in nursing and medically trained. So certainly, I mean, they already have that skill.
I think that's right. I think engaging the people who already have that role in the community is very important, but also interrogating what are their traditional practices, because sometimes they actually don't agree with a good outcome. And so, but obviously if you ignore that section of the traditional birth attendant population, then you're ignoring some practical experience and potentially encouraging them to proceed with practices such as unhygienic cutting of the cord and things like that. I think when they're brought into the fold and trained, hopefully that would give the most ideal outcome. But I think that's maybe why you see discrepancies in past policies to do with traditional birth attendants versus favouring midwives. We can't possibly probably train enough midwives ideally, so you do have to kind of mix the two, I think.
Yeah. You're quite right. So it's important to work with the community leaders when you want to do some change, and particularly with women who have a very close relationship with the community there. And it's important that you work with them rather than doing things to them.
Yes. No. The worst thing is to walk in and assume you know more, as you've said. Something that the reproductive health workers at the clinic were very proud of was that they, unlike what they felt happened in Western countries, they said we encourage the male partner to come in, we encourage immediate skin-to-skin contact. None of this taking the baby away into another room, and which is, to recent times perhaps what happened quite frequently in Western countries, and so and those were features that they valued very highly, and we do too. And so it was kind of shared kind of goals between their traditional beliefs versus our beliefs.
Any other questions? Go for it.
Hi, my name's Simon. Just a question generally. I feel like in Australia, I have a best friend who's studying medicine, and I feel like he's been at university forever. What's the trade-off between quick responses, training people in enough to have sort of an immediate impact in a lot of areas, and then training people over a longer period of time to be able to deal with a broader range of problems, I guess? And is that something that I assume that's something that's being considered, and where is development heading in that area between training people for 8 years to be able to handle every possible problem ever, as opposed to training people for 1 year to deal with immediate problems?
Minimum of 8, isn't it? The minimum of 8. Nesrin and Nicole, you can probably both talk to this, but Nicole, do you want to?
I think that where there exists a structure like a medical school in a country that has security and stability, then it's entirely appropriate to train a certain proportion of people to become doctors, and for them to perhaps then get experience in neighbouring countries and overseas. And I think that's something that's certainly possible in Africa and certain African countries. Where those structures don't exist and there aren't universities, then you tend to try to take some of the brighter and more motivated people. You can try and get them scholarships in nearby countries and to go into medicine training. But it's a huge economic kind of burden to that person and a bit of putting all your eggs into one basket for that individual. So that's why where those structures don't already exist, you tend to go for a model of training that's at a safe and competent level, and where people know the limits of their skills, and that's where the African and Asian model of a healthcare worker that's not a doctor tends to focus on people who are competent and then know the limit of their skills. If they have a referral place, know when to refer, and if they don't, then they are really the best. They are really the best bet. So.
And just continuing on from that, Nicole. So the hospital where I worked at, there was an anaesthetic technicians. In Australia, we have anaesthetists who are trained for, by the time they finish, they would have trained and studied for about 14 years. And the anaesthetic technicians there, they study for 3 years. And he was fantastic. He was amazing. He was extremely competent, and we learned things from him even. And also going on from that, in terms of bringing about change, I have also learned that you have to be very patient. That change takes a long time, and it starts by just going somewhere and, becoming friends and getting people's friendships and getting that trust and just really listening and not really doing very much, but just listening. And then it takes lots and lots of visits before you can start to, bring about change with them.
Next question here.
Hi, my name is Yves Augustin. I'm also a student from UNSW in Kensington. I'm originally from Haiti. I thank you so much for this presentation. It's funny, even though I was a male student, but I've been interested in maternal health and actually female circumcision when I was studying in the United States. I have noticed that some of the studies have shown, for example, that training traditional birth attendant actually does not reduce, maternal mortality. However, it has increased, for example, visitation to the hospital because, the mothers after they give birth, they're more encouraged to take the child, to the hospital, for shots and stuff like that. Like you were saying, Nicole, the problems are very complex, but my problem is with the MDGs, of course they were set up, but then they are not context specific. And we've noticed, I guess, maybe for the last 100 years, that usually they set up those goals, but they're not context specific. But then in the meantime, we can see that, we're not going to meet those goals. So my thing is, I'm wondering when and how for major players like WHO, the World Health will have this will implement or incorporate this kind of social perspective in whenever they're going to set up an agenda, so that, at least they can get closer to their goals. Because it seems like, we keep making the same mistake over and over again. And for example, I was doing something on Haiti. Well, first of all, we have no money, whatever. And then last year with the earthquake, so we were even further from, meeting especially the MDG 4 and 5. So we could see something like that, how can we learn from those things that we learn, especially from a social perspective? Because the thing is yes, we're financially poor, we, politically, in disarray, but socially, the people are saying, we can work, like you were talking about, community working, grassroots, we can learn from something like that and implement that social perspective to the world leaders, on the international level.
Thank you. Nesrin, would you like to?
Yes, thank you very much. That's an excellent question. And you're quite right. We are making the same mistakes over and over again. And in some countries, we actually have fallen back. We're actually going backwards rather than even forwards. And I think there are two things which I find which are probably important. Number one is that, as you said, you need to take the cultural context into the equation. It's very important. You can set up the best hospital somewhere, you can have the best doctors and nurses, but it's not going to be used for whatever reason. The woman may not understand, they may not be allowed to go, they may not have any babysitting facilities. So You need to work with the community and ask them what they want and what would help them to seek the medical help, and work with their traditional birth attendants and get them on board and get their community and religious leaders on board. So, and number two, when we count maternal mortality rate or illnesses and things like that, we need to stratify it to the different groups in a country. You need to stratify for the indigenous communities, because often, and as Nicole has just said, some communities may not use the hospital or the health facilities for whatever reason. They may not be treated well, or there may be things there where they can't do their traditional ways of delivering a baby. So the culture is definitely important, and if we don't take that into account, you're right, things will not change.
And last question over here.
I really just was going to add something, if that's all right.
Please.
It was really around the world is now looking at transitional education, and it's looking at globally competent practitioners who are locally relevant, and I think that's what some of our panel were talking about. And I think some of our local examples in the Pacific have shown where traditional birth attendants have been overseen by midwives and had some level of training to ensure they have safe practice, but also very much include the culture of that environment to make sure that both the outer areas are covered, because as we know, primary health care is the majority of the healthcare provided in those areas, and I think our Western models often focus on the hospital a lot more. So I was really just trying to add some of those, and not very good question, I'm sorry.
One thing that's run through all of this that I just want to ask you about finally is the improvements in maternal and child health are contingent upon the health system, the overall health system of a country. Can one exist without the other? Can you work on one without the overall health system being improved?
I quite like to think that when we focus on specific programs for women's health, that they have an amazing positive spin-off for general health as well, and not just in what we were talking about in terms of improving this cycle of health, but as you all know, that there's some very good specific programs into the prevention of maternal transmission of HIV, and in the area that I worked in that brought HIV out into the open, it made something that was quite stigmatised worth diagnosing. People knew that it was actually worthwhile detecting HIV in the mother, preventing it in the child, and it all made sense. And in those open discussions, it destigmatised HIV for the broader population as well, for men and as well as women. And I think men in our area probably benefited from that. And in fact, there's been so much focus in our area on women's health that men are clamouring for men's health as well. Just as they are in the West. And not to say that we've solved any problems by any means, or solved all the problems, but just that there are positive spin-offs that I think you can see.
So coexist and support each other, I suppose. But, I'd like to thank you for all joining me here, and thank you for watching online. Mahboba, you wanted to add something about asking for some support for your organisation.
I just request each and every one of audience here, or anyone who watching us, to please help us help Afghan women, and if you guys sponsor one woman to for hygiene or for their health issues, or if you have a bit of time to come and work volunteers at my organization, and even if you change one life of one woman, please do that. So just don't ignore them. Just give them a hand, and they do need healing hand. So we need a lot of healing hand. So please come forward. They can check my website at mahbobaspromise.org, or do whatever you can to help us.
The website will be on our credits as well. And Mahboba's running the organisation on her own, and it's doing a lot of good service. So, as she told me earlier, $50 a month could sponsor a woman in Afghanistan. I hope you can all join us in a month's time for another Praxis. And if you'd like to subscribe to the podcast of Praxis or watch episodes online, please go to worldbank.org/Praxis. And thank you very much to our panellists, Nesrin Varol, Mahboba Rawi and Nicole Wong. Thank you.
Thank you.